Pseudomonas, other non-fermenters, Haemophilus, Bordetella, and Brucella. First one is the non-fermenters. Non-fermenters will utilize the sugars oxidatively. The important members are Pseudomonas, Burkholderia, and Acinetobacter. First one is the Pseudomonas, the virulence factor and pathogenesis. Colonization to colonize the host surface by pili or fimbria. Their organ of attachment is seen in Pseudomonas. Toxin mediated immune evasion and tissue injury. Non-indiffusible toxins, example exotoxins such as SUT and Y. Some diffusible toxins such as exotoxin A, proteases, phospholipases, hemolysins, elastases, pyocyanin, etc. is seen, and host inflammatory response against lipid A of lipopolysaccharide and flagellin. Pigment production. First one is the pyocyanin. It will produce blue-green pigment, which is produced by Pseudomonas aeruginosa. Fluorescent or pyoverdin. It will use greenish yellow color. It is produced by all the species. And the other one is the pyorubin. It will impart red color. And the pyomelanin. It will impart brown and black color. Alginate coat, mucous strains of Pseudomonas, it will have a slime layer or alginate layer. It will facilitate biofilm formation, and this alginate coat it will help in adhesion to purulent mucus. Certain stain will cause infection in patients with cystic fibrosis. Capsula polysaccharide, it will prevent the bacteria from phagocytosis. Multi-drug resistant and multi-disinfectant resistant, wide temperature range of about 5 to 45 degrees Celsius. Clinical manifestation of Pseudomonas. Most of the infection are mainly encountered by the hospitalized patient. The most common infection is pneumonia. Mainly ventilator-associated pneumonia is seen. Chronic respiratory tract infection will occur in patients with cystic fibrosis. It is mainly seen in Caucasian populations. Bronchiectasis or chronic panbronchiolitis, which is seen mainly in the Japan. Mucoid strain, which possessing alginate layer or Pseudomonas, will commonly cause infection. Some structural abnormalities of airway tract that will result in mucostasis. Ear infection will occur. Simmers ear. It is more common among children. Malignant otitis externa. It is seen mainly in the elderly diabetic patients. Eye infections such as corneal ulcers are seen mainly in persons in contact with lens wearers, and endophthalmitis is seen. Shanghai fever. It is a mild febrile illness. It will resemble just like the typhoid fever. Next one is the skin and soft tissue infection. Burn patients, Pseudomonas is the most common organism to infect the burn wounds. Ecthyma gangrionism, it is an acute necrotizing condition that results from bacteremia. It occurs more commonly in patients with febrile neutropenia and AIDS. Pseudomonas dermatitis, it causes outbreaks in spas and swimming pools. Toe web infection, it is mainly seen in the tropics. Green nail syndrome, it is a parenchyma results from prolonged submersion of hands in water, it is seen. Other infections such as cellulitis, in cellulitis which is characterized by blue-green pus formation is seen. Bone and joint infections such as osteomyelitis and septic arthritis is seen. Meningitis is seen in post-operative or post-traumatic patients. Urinary tract infection is seen in catheterized patients. Laboratory diagnosis of Pseudomonas. It is non-fastidious, obligate aerobe, and it is motile with single polar flagellum. It will produce large, opaque, irregular colonies with metallic sheen, which is iridescence. Diffusible pigments blue-green, which is pyocyanin in yellow-green, pyoverdin pigmentation. Pigment production can be enhanced in special media such as King's media. Most colonies have characteristic sweet ether or alcohol-like fruity odor seen in Pseudomonas blood agar. It will produce beta hemolytic colonies and blood agar. McConkie agar. It will produce pale non-lactose fermenting colonies. Selective media such as centrimide agar is used. Oxidase and catalase test is positive in Pseudomonas. It is a non-fermenter. It will not ferment any sugars, but it will utilize sugars oxidatively. Oxidative ferment test, it will show oxidative pattern. It is based on Hug and Lesion oxidative ferment test. First one is the Burkholderia. Burkholderia species are mostly oxidase positive. It is non-fermenter. It will differ from Pseudomonas in being. In Burkholderia, it is bipolar stain. It will appear like safety pin appearance. Burkholderia pseudomallei, which is otherwise known as melioidosis. It is a causative agent of melioidosis. The clinical feature of melioidosis is characterized by mainly pulmonary infection is seen. In with pulmonary infection, abscess is seen, pneumonia, severe necrotizing lung disease, to chronic pulmonary tuberculosis is seen. In melioidosis, skin ulceration and limb adenopathy is seen. Long latent period, this disease is called as Vietnam time bomb. Bioterrorism, Burkholderia pseudomallei, it is used as a potential agent of biological warfare. Ashdown medium is used for diagnosis of Burkholderia. Burkholderia malae, it is a pathogen of horses, causes glandus, nasal discharge, ulcers in the nasal septum, and FASI. FASI means skin lesions and lymph node involvement will be there in FASI. Human infection is characterized by local skin nodules and lymphadenitis is seen. It is transmitted mainly by inoculation. Pneumonia, ulceration of trachea and sepsis is seen. If transmitted by inhalation, this pneumonia is seen. Burkholderia malay, it differs from Burkholderia pseudomallei in being non-motile and oxidase negative, inability to grow on McConkie agar, inoculation into guinea pig, it will cause testicular swelling, which is known as Strauss reaction. Next one is the Burkholderia cepacia. It is currently most commonly encountered Burkholderia species. It will inhibit moist environment, detergent and IV fluid. Lipopolysaccharide of Burkholderia cepacia is among the most potent of all other gram-negative bacteria. In Burkholderia cepacia syndrome will occur. In cepacia syndrome, mainly fatal respiratory infection, septicemia, and cystic fibrosis patient is seen. Nosocomial pathogen in ICU patients because as it is resistant to multiple antibiotics, it is seen. Next one is the ACINETOBACTER. It is a saprophytic bacilli. It is recognized as nosocomial pathogen. Mainly it occurred from hospital acquired infection. It will cause ventilator associated pneumonia, central line associated bloodstream infection, and other catheter associated urinary tract infection is seen in Acinetobacter. Wound and soft tissue infection and infection in burn patients. Acinetobacter baumannii is a non-fermenter, but it differs from Pseudomonas, being oxidase negative and non-motile. Next one is the Haemophilus. Haemophilus are oxidase positive and capsulated pleomorphic gram-negative bacilli. It prefers bacillus is blood-loving organism. It will request two accessory growth factors present in blood. Factor 10, hemin present freely in blood, and factor 5 is an NAD. It is present inside RBC. Next one is a virulence factor and typing. Capsule based on capsule polysaccharide. Haemophilus influenza is totally typed into 6 serotypes from A to F. Haemophilus influenza serotype B is the most virulent among the all type. It is most invasive infection. Haemophilus B capsule has unique chemical structure and it is made up of polyribosylribotyl phosphate antigen and it is strongly immunogenic. Hence, Haemophilus B capsule antigen is used for vaccination. Next to Haemophilus B, non-typable strains are commonly isolated clinically. Other capsular serotypes are very rarely isolated. Haemophilus influenza was the first free organism whose entire genome was sequenced. Next one is the clinical manifestation of Haemophilus influenza type B. It is one of the most common and most invasive serotype in which central nervous system infection is seen. Pyogenic meningitis is seen in less than 2 years of age. Subdural effusion is seen in Haemophilus influenza type B. The most common complication is CNS complication and in epiglottis seen in older children 2 to 7 years with absence among Navajo Indians and Alaskan Eskimos. Lobar pneumonia in infants will occur. Less common invasive condition is seen in children. In children, cellulitis of neck and head region will occur. Osteomyelitis, septic arthritis is seen. Orbital cellulitis and endophthalmitis is seen. Next to Haemophilus B, non-typable strains are the most commonest group clinically. It is non-invasive. It is spread by contagious spread. Usually it will affect the adult. Some common clinical manifestation are in childhood, otitis media will occur, exacerbation of COPD. They are the most common bacterial cause for this condition. In adult, pneumonia will occur among patients with COPD or AIDS. Puerperal sepsis, neonatal bacteremia by strains of biotype 4. Sinusitis is seen in adults and children. Laboratory diagnosis of Haemophilus, specimen collection and transport, CSF, blood, sputum, pus, aspirate from joints, middle ears or sinus it is collected. It is highly sensitive to low temperature, so the specimen should never be refrigerated. Gram staining of CSF and other specimen, it will show pleomorphic gram-negative Coca bacilli. Capsule detection, it is by Coulomb reaction or latex agglutination test. Culture of Haemophilus influenza is largely aerobic. The growth is enhanced by 5 to 10% of carbon dioxide. Blood agar with Staphylococcus aureus streak line. Colonies of Haemophilus influenza, it will grow adjacent to Staphylococcus aureus streak line. So this property is known as satellitism. It is done to release of factor 5 by lysis of RBC, which is mediated by Staphylococcus aureus. Chocolate agar, it will grow well on chocolate agar, but sparsely on blood agar. Filz agar and Levindal agar is used for culture. Next one is the test for factor 10 and 5 requirement. Require only 10 factor, Haemophilus ducrani and Haemophilus aprophilus. It will require only factor 5. Haemophilus para-influenza, Vibrio para-hemolyticus and Haemophilus para-horphilus. It will require both factor 5 and 10. In Haemophilus influenza, Haemophilus aegyptius and Haemophilus hemolyticus. Next one is the biotyping. Biotyping is mainly done by indole urease test and ornithine decarboxylase test. Next one is a slide agglutination test. Serotyping is carried out by type-specific antisera. Haemophilus influenza B conjugate vaccine. The PRP capsular antigen of Haemophilus influenza type B is used as a vaccine because capsular antigen are purely immunogenic to children. They are conjugated with adjuvants such as diphtheria toxoid and tetanus toxoid. It will reduces the rate of pharyngeal colonization with Haemophilus influenza B. Conjugated vaccines are reduced due to incidence of Haemophilus influenza B disease. Next one is a Haemophilus aegyptius. It is a coarse, weak bacillus in which pink eye syndrome is seen, which is otherwise known as Egyptian ophthalmia. And Brazilian purpuric fever is seen in Haemophilus aegypticus. Next one is the Haemophilus ducreyi. It will causes chancroidas of sore in which the painful limb node, tender, non-indurated and bleeding and gentle ulcer is seen. With chancroid, it will increases transmission and degree of susceptibility to HIV infection. Indirect smear, pleomorphic gram-negative coca bacilli, it will show bipolar staining. It will occur in parallel chains, which is called a school of fish or railroad track appearance. Antigenetically, it is homogeneous. Next one is the Haemophilus aegyptius. It is also known as Koch weak bacillus. It will closely resemble Haemophilus biotype 3. It will cause Brazilian purpuric fever. Brazilian purpuric fever, it is a fulminant condition in which fever, purpura, hypotension and shock is seen. Purulent contagious conjunctivitis, which is known as Egyptian ophthalmia. Cat group organism. It are highly fastidious. It is gram-negative bacteria. Normally, it will reside in the oral cavity at commensal, but occasionally, mainly it is seen in local infection in mouth and systemic infection, such as bacterial endocarditis. It is seen. Haemophilus species: Haemophilus aprophilus, Haemophilus paraprophilus, Haemophilus parainfluenza. Aggregatibacter, formerly it is known as Acinetobacillus, Acinetomycetoma comitans. It is the most common member. Cardiobacterium hominis, Echinella corrodens. It will produce twitching or jerky motility, and pitting or corroded colonies are seen on blood agar. Next one is the Bordetella. It is first described by Bordet and Genge. It will cause violent paroxysmal productive cough. Mainly it is seen in children. It is otherwise known as whooping cough or 100 days fever. Virulence factor of Bordetella is pertussis toxin expressed only by Bordetella pertussis. It is similar to the cholera toxin in its structure and function, in which increased CAM test is positive, and other toxins such as tracheal cytotoxin, adenylate cyclase toxin, dermononecrotic toxin, and endotoxin are the virulence factor. Adhesin, it will play a main role in bacterial attachment. Filamentous heme agglutinin, protactin, it is an outer membrane protein. Fimbriae or pili are agglutinogens. Next one is the clinical manifestation. In Bordetella, mainly whooping cough will be seen. It will pass through 3 stages. The incubation period of Bordetella is 7 to 10 days. First one is the catarrhal phase. In catarrhal phase, it will last for 1 to 2 weeks. In catarrhal phase, mainly common cold-like non-specific symptom will be there. Catarrhal phase is mainly highly infectious stage. Smear and culture are likely to be positive in catarrhal phase. Second one is the paroxysmal phase. It is characterized by specific symptoms such as in which whooping cough and post-UC vomiting will be seen. In this stage, patient is less infectious and smear culture will become negative in paroxysmal phase. Another one is the convalescent stage, in which the severity will decreases. Antibodies appear in serum. Next one is the differential diagnosis: Mycoplasma pneumonia, Chlamydophila pneumonia, adenovirus, influenza and other respiratory virus, use of angiotensin converting enzyme inhibitors, reactive airway disease, gastroesophageal reflux disease are the differential diagnosis. Next one is the epidemiology of Bordetella. whooping cough is exclusively it is a human disease. There is no animal reservoir in this source. Early case in catarrhal stage or the main source. There is no carrier stage. Most commonly, it will affect less than 5 years. Mode of transmission, it is mainly through inhalation of droplet. Rarely by direct contact, it will spread. Recent outbreak is seen in Washington epidemic effect in 2012. There is no cross protection to Bordetella parapertussis infection. Next one is the laboratory diagnosis of Bordetella. Best specimen nasopharyngeal secretions, which is obtained by nasopharyngeal aspiration, which is the best method, or per nasal swab. Types of swab are used are alginate swab, followed by Dacron swab for culture is used. PCR is used. Only Dacron or Rayon swabs are recommended for PCR. If delay is expected, suitable charcoal based transport medium such as amids or Stewart medium can be used. Cuff plate method, post nasal swab, it is used and it is no longer recommended. Next one is the antigen detection, direct fluorescent antibody test of nasopharyngeal secretion. Culture, nasopharyngeal aspirate culture is the gold standard method for Bordetella. Media used are Regan and Lowy media. Bordet Kengu glycerin potato blood agar is used. Colonies, mercury drops or bisected pearls appearance is seen. Culture smear, it will reveal small ovoid cocoa bacilli. It will be arranged in thumbprint appearance. Capsules and bipolar metachromatic granules, it will seen occasionally. PCR is more sensitive. It will give the results very quickly, but it to be standardized properly. The most common targeted genes are IS481 and promoter region genes. And antibody detection enzyme immunoassay detecting immunoglobulin A and G to pertussis toxin, filamentous heme agglutinin. Next one is the vaccine used for Bordetella. One is the whole cell pertussis vaccine. It is prepared by heating, followed by chemical inactivation and purification of whole Bordetella pertussis bacilli. It is given along with DPT to children less than 5 years. In which the in whole cell pertussis vaccine, the efficacy is very good, average about 85%. Adverse effects, common fever, injection site pain, erythema, swelling, and irritability will occur. Very rarely, neurological complication and hypotonic, hyporesponsive syndrome will occur. It is very rare after vaccination. Next one is the vaccine is contraindicated in children greater than 5 to 6 years of age. It is associated progressive neurological condition or family history of epilepsy, hypersensitive to previous dose. Next one is the acellular pertussis vaccine. It is composed of pertussis toxin greater than 2 other bacterial components such as FHA, pertactin or fimbriae. Efficacy is same as a whole cell vaccine. It is associated with few side effects and it is safely given after 5 to 6 years. Next one is a brucella. Brucellosis is the disease affected by brucella. Mostly it will spread by the zoonotic spread. It occurred from animals such as sheep, goat or cattle. NOMEN system classification of brucella. DNA hybridization reveals the brucella are very closely related, probably represent variants of it is a single species. Sake of convenience, this can be classified into NOMEN species. Totally 6 nomen species are identified. It is further classified into several biovars. Bordetella, Brucella militensis, it will infect sheep, goat, and camel, and it has 3 biovars. Brucella abortus, it will infect cattle and buffalo. It has totally 9 biovars. Brucella suis, it will infect pigs. It has totally 5 biovars. Brucella canis, it will causes abortion in dogs. Brucella ovis, it will cause reproductive disease in sheep. Brucella neotomy, it will infect desert rodents. Next one is a pathogenesis. Bru- Brucella melitensis is the most pathogenic, followed by Brucella abortus and Brucella suis. Human infection is the most common and it is extremely sometimes rare. Transmission is mainly seen from infected animals to man. There is no evidence from man to man transmission. Direct contact is the most common spread from the infected animal tissue. Ingestion of raw milk or dairy product and sometimes airborne is also there. Organs affected, Brucellosis facultative intracellular pathogen. Mainly, it will affect the organs of reticuloendothelial system and it will cause infection. Incubation period of Brucella, it will vary from 1 week to several months. The onset is often and it is very insidious. Clinical manifestation of brucella. Classical triad in brucella, like typhoid, it will have fever with a night sweat. Arthralgia, arthritis, and hepatosplenomegaly will occur. Brucella is a typhoid-like illness. Brucellosis, it will resemble same like the typhoid, except it is less acute and less severe, with undulating pattern of fever, or Malta fever or Mediterranean fever will occur in brucella, and more musculoskeletal symptoms will be there in brucella. Laboratory diagnosis of brucella, culture and identification, sample, blood, bone marrow, CSF, joint fluid or other tissue. Culture media such as biphasic blood culture bottles media, castanets media is used, which is made up of brain heart infusion, growth or agar. Erythritol, it will improve the growth. Automated techniques such as backtech and backtower alert system is used. Next one is the antibody detection by standard agglutination test. It is one of the gold standard test serological tests. It is a tube agglutination test which is used for the detection of antibodies by using standard strain of Brucella abortus. Standard agglutination test, it will detect immunoglobulin M antibodies against antigen of smooth lipopolysaccharide. It is useful for acute brucellosis. False negative standard agglutination test, it occurs due to prozone phenomena. It occurs due to a prozone phenomena means due to excess of antibody in patient sera, it will occur. In this condition, false negative will occur. Presence of blocking or non-agglutinating immunoglobulin G or immunoglobulin A antibodies. False positive SAT may occur due to antigenic cross-reacting gram-negative bacteria such as E. coli. C. Complementary fixation test and ELISA is preferred in chronic brucellosis and antibody detection. Other tests are performed, such as PCR using primers for RRS, RRL gene, OMP2 gene. Brucellosis skin test is done. Guinea pig inoculation, Tbilisi phage typing is done. Diagnosis of brucellosis animals is mainly by antibody detection in milk by milk ring test is done. Rose Bengal card test and whey agglutination test is done for the diagnosis of brucella. Thank you.